Today we're going to be looking at pheochromocytomas and the functions of adrenaline. Before looking at the condition, we have to first of all acknowledge the structure and functions of the adrenal glands. So if you remember, we have our adrenal glands which sit on top of our kidneys, and we can zoom in and see the different layers which compose each adrenal gland. The topmost layer is called the zona glomerulosa, and this is responsible for secreting mineralocorticoids like aldosterone. The second layer is the zona fasciculata, and this secretes glucocorticoids like cortisol. The third layer down is called the zona reticularis, and this is responsible for secreting androgens or sex hormones. And then the final layer is the adrenal medulla, and this secretes catecholamines like adrenaline and noradrenaline. For the purposes of this video, we're mainly going to be focusing on the adrenal medulla, as this is the layer which is affected in pheochromocytomas. Another aspect to recap is the functionality of adrenaline. What normally happens is that there's an external trigger, such as stress, which causes the adrenal glands to secrete adrenaline into the bloodstream. This adrenaline then acts on the alpha and beta adrenal receptors, triggering the fight or flight response. And the main functionality of this is to activate the sympathetic nervous system. And this has multiple effects on the body. For example, there's increased blood pressure due to vasoconstriction. There's increased cardiac output, mainly due to an increased heart rate. There's increased glycogenolysis and muscle contraction, increased respiratory rate, and increased sweating, all caused due to the functionalities of adrenaline. Okay, so now that we've covered the functions of adrenaline, we can turn towards the condition in question. The word pheochromocytoma can actually be broken down. Pheo means dusky, chroma refers to color, and cytoma means tumor. And looking at the central component of the word chromo, this actually refers to the chromaffin cells which form the adrenal medulla. And these are the cells which secrete catecholamines like adrenaline and noradrenaline. And pheo, dusky, basically means that these chromaffin cells turn darker as they become tumorous. So putting all of this together, a pheochromocytoma is a catecholamine-secreting tumor of the chromaffin cells. So what can actually cause a pheochromocytoma? Well, the majority of cases are actually idiopathic, with the remainder carrying a genetic component. So just recapping the process, a tumor sporadically forms inside the adrenal glands, and more specifically, the adrenal medulla. And what happens is that the tumor cells begin secreting excess adrenaline, and this excess is what causes the signs and symptoms of the condition. And it's important to note that most tumors formed this way are actually benign rather than malignant. Turning towards the genetic pheochromocytomas, again there's a tumor which forms inside the adrenal medulla, but it's related to a condition such as multiple endocrine neoplasia 2A or 2B, or von Hippel-Lindau syndrome, or others. And these conditions basically increase the risk of tumors forming throughout the body. And it's this genetic predisposition which leads to pheochromocytoma formation. We can actually work out the signs and symptoms of pheochromocytoma by realizing what the adrenaline normally does within the body, and then extrapolating to see what would happen if there's too much adrenaline. So for instance, adrenaline increases the heart rate, so an excess would lead to tachycardia. Additionally, adrenaline increases blood pressure, so too much adrenaline in pheochromocytoma could lead to hypertension or headaches if the blood pressure increases too much. And we also know that adrenaline increases sweating, so too much adrenaline would lead to excess diaphoresis. And it's important to know that this is the classic triad of symptoms in pheochromocytoma. And these symptoms are episodic, meaning that they are sometimes occurring rather than constantly there. So it can sometimes be a bit difficult to detect. Other symptoms might include anxiety, tremor, or weight loss, and this is all related to the increased levels of adrenaline in the bloodstream. Turning towards the diagnosis of pheochromocytoma, the first line investigation is usually 24-hour urine testing. And the way this works is that we measure the urine for raised catecholamine metabolites, which are basically the breakdown products of adrenaline or noradrenaline. And if these are raised beyond 2 times the upper limit of normal, it suggests a diagnosis of pheochromocytoma. In a similar way, We can do blood tests as well, which measure plasma-free metanephrine levels, but the only trouble with this is that they sometimes produce false positive results. So 24-hour urine testing is usually preferred. And finally, we might turn towards some imaging such as CT scans or MRIs, which help to localize the tumor in the adrenal gland. And just as one example, we can see quite a large pheochromocytoma on the right-hand side here. In terms of the management of pheochromocytoma, the treatment options can be broken down into medical and surgical. The medical management usually occurs before surgery and involves alpha blockers such as phenoxybenzamine, as well as beta blockers like atenolol, being given to the patient in order to control the blood pressure. And this is very important to improve the outcomes during the surgery itself. The surgery is the definitive management and usually involves a laparoscopic adrenalectomy, where the adrenal medulla tumor is removed and cut out from the adrenal glands. It's important to follow up these patients as well to ensure that there's no recurrence of the condition. Okay, so just to finish off, we have a quick clinical case here. A 38-year-old male presents with episodes of tachycardia, hypertension, and headaches. Each episode is sporadic with no specific trigger and lasts a few minutes in length before it subsides. Given the most likely diagnosis, which layer of the adrenal glands is most likely to be affected here? So from this case, you can tell quite clearly that this is a pheochromocytoma being presented, and the layer which is most commonly affected is the adrenal medulla. As a follow-up question, what is the gold standard investigation for his condition? And in this case, the answer would be 24-hour urine testing, checking for the presence of catecholamine metabolites, and usually beyond 2 times the upper normal limit. And here is a summary slide explaining everything I've gone through in the video. If you have any questions, please leave them in the comments, and I'll see you in the next video.